Thank you very much. It's an honor and privilege to be here, and it's great to be the first punching bag of the day. So who here uses staple line reinforcement? Who here does not? Ooh, it's a little more than I expected. Here we go. All right, so we're talking about no reinforcement required, specifically talking about sleeve gastrectomy. I listed my disclosures. None of them are relevant for what I'm talking about today. Sleeve gastrectomy, as we all know, multiple different techniques, the size of the bougie, distance from the pylorus, where you veer from the GE junction or whether you go quite tight, Belsey's fat pad, some resect it routinely, other people stay away from it, dissection onto the left cruce or not, stomach versus short gastrics will be talked about later on. I'll be focusing on staple line reinforcement and also oversewing and how that relates to it. But there are also a lot of other techniques, fibrin glue, omental reinforcement, leak test with saline, air, endoscope. So there's a lot of different ways to skin this cat. I'll be focusing on staple line reinforcement, but you can't just focus on that in isolation. It's a package deal. So what we look at later on with regards to data, you have to take that all into perspective because you just can't look at one variable when there's so many different variables that we're looking at. So staple line reinforcement, I'm specifically talking about buttress material here. There are a lot of different products out there, pericardium, porcine related, biosynthetic. I'm not going to get to specifics with regards to those products, but when I say staple line reinforcement, I'm not talking necessarily about oversewing. I'll say that separately. I'm talking about the stuff that goes between the staples themselves. So how can we answer this question? A randomized clinical controlled trial. We could never do it. Thank goodness, and everybody should pat themselves in the back, our leak rate is 0.24%, not 2.4%, 0.24%. Our bleed rate is 0.26%. Those are small numbers. That means any kind of randomized controlled trial is not feasible because the large numbers needed to get adequate power. So we should all be proud of that, but it also makes data in this area very difficult. So, no randomized controlled trials. Next best evidence, well, it's certainly not single surgeon, single institution. So when you start looking at those studies out there, just move on. Because those numbers are so low, you're not going to learn anything from my 1,000, my 2,000, my 3,000 cases. It's just not possible with those low numbers. So you need large observational studies. They're generalizable, they can reflect real-world practice, but they lack the granular details, and that's the problem. Big problem here is we can tell what was done, whether staple line reinforcement was used, but we don't know if preoperative or intraoperative decision-making made the impact of your choice to do staple line reinforcement, and whether oversewing was done and that decision was made before or after. If you came across it with your stapler and you said, this doesn't look quite right, so I'm going to oversew this one, but I usually don't. That's going to be a different case, and how do you take that into account? That's really challenging, especially when you're looking at large observational data sets. So one way to do that is to do surgeon-level analysis. So this helps mitigate the intention to treat problem. Surgeons use specific techniques routinely. Certain cases require additional maneuvers in attempts to prevent complications like I just talked about. And so by using the data to assess what a surgeon's customary or usual practices, hopefully we can better identify their intentions. Now that's a leap. It's not a randomized controlled trial. It's not a prospectively open the envelope and try to figure out what you're going to do. But hopefully that's our best guess to try to get out what the intention was from the surgeon. So I'll talk about surgeon level measures, whether it's routine use it 90% of the time, selective use between 10 and 90% of the time, or surgeons who do neither. So less than 10% of the time they use one of these techniques. Looking at the MBS AQIP data, so the ACS BSCN program and the ASMBS BOLD program combined in 2012. So starting in 2012, we were able to collect some of this data. And this was around the same time that the sleeve was being done in increased numbers. So as we developed this data collection program, we added specific sleeve technique variables, distance from the pylorus, staple line reinforcement, oversewing, bougie size. Now, the MBS QIP data has 100% of cases. It's data collected by trained surgical clinical reviewers. It's not administrative data. It has bariatric-specific data points with leaks and bleeds and risk-adjusted made by the definitions made by surgeons. It has longer-term follow-up and currently captures about 95% of all bariatric operations in the United States. So, specifically focusing on staple line reinforcement, this is a study, the first study from the MBSA QIP from 2012 to 2014. So you have to think about the timeline here, looking at staple line reinforcement. Now, staple line reinforcement is as I described it above, but again, the devil's in the details here. So the specific data definition I think I listed here, because this is what the surgical clinical reviewers look at when they're talking about staple line reinforcement. And so basically it lists some of the products that are available, and it says it's not glue, it's not fibrant glue, it's not clips or things like that, it's not oversewing. That's different so that people understand what it is. With regards to the definition for oversewing, you can see that a majority of the suture line has to be oversewn. So if you're just sewing a little bleeder or just sewing a little notch or something that you're not happy with, doesn't qualify as oversewing. So what does it look like? Well, looking at 190,000 cases from 1,600 surgeons from across the country, we found, similar to this room, that 80% of the people use staple line reinforcement and 20% of the people use no staple line reinforcement. But as you can see down here at the bottom aspect, there was a clicker here, but that's okay. Oh, there it is. You can see here there's a hodgepodge of just oversewing, selective oversewing, just staple line reinforcement, selective staple line reinforcement, and trying to put that all into perspective here. But overall, about 80% of cases or surgeons use staple line reinforcement. And so what did we find from that? Well, from this study from 2012 to 2014, we found that the leak rates were higher compared to doing nothing. So staple line reinforcements had a higher leak rate, but a lower bleeding rate. And here's the data here. So the leak rate with regards to staple line reinforcement was about 1% or 0.96% and down to 0.65%. Now this was 2012 to 2014. I just quoted a rate of 0.26%. So we've come a long way from 2012 to 2014, and we should be really proud of that. So take that into perspective when we're looking at this, but staple line reinforcement, higher leak rate, lower bleed rate. When we did risk-adjusted analysis as well, this was still statistically significant, as shown here, with regards to leak rates and the bleed rates. However, when we did that surgeon-level data, when we looked at the surgeons in their usual customary practice and broke it by there, again, to try to differentiate between their intention of what they were trying to do in the operating room, try to get rid of that one case where you happened to oversew because you weren't happy with that staple line. You intended not to use the oversewing, but you did probably in that situation. Again, assumptions. But when we looked at that, the routine reinforcement had a higher overall leak rate, and that was statistically significant, whereas the bleed rate was no longer statistically significant. You can see this confidence interval crosses 1, and this does not. So the overall finding from this was that staple line reinforcement was associated with increased leak rates, and at the surgeon level, leak rates remained significant, but bleeding events became non-significant. A lot of limitations. I already went over them, not going to go over them in detail. Observational study, a lot of different data points that we're not looking at, a hodgepodge of techniques that aren't taken into account here. So a lot of this has to be taken with a grain of salt. We didn't talk about the type of staple line reinforcement used. We don't know which specific product. Was it pericardium? Was it biosynthetic? How thick was it? How thick were the staplers? Which kind of staplers? None of that was included in here. It's a large national data collection program, so all that detail isn't in there. And if we included that, the clinical reviewers would kill me. So with regards to staple line reinforcement not collected in this, we know that they're quite expensive. So it's been quoted up to $200 per fire, adding additional costs between $650 to even up to $3,500 dollars per case with regards to the cost here. And that has to be taken into consideration as well. So conclusions from that study, a surgeon should consider the risks, benefits, and costs of the surgical techniques when performing a sleeve gastrectomy and decide in their hands what is best for them to do. Now, since that time, more data has come out. So the MBSA QIP has released this data set for everybody to use. Who's used the data set so far? A few hands. Next time I want to see a lot more. So all this data is available. Participant use file, people can have access to the data, and some people did some studies using this. So from 2015 on, the participant use file is available for all those. So I'm going to highlight 2 specific patients that looked specifically at staple line reinforcement that have been done since then. So this study here by Demusi et al. Was published in SWORD in July and specifically looked at staple line reinforcements. in these new data that I was talking about before, this is where the leak rate is 0.26%, 2.24%, and the bleeding rate is 0.26%. So those rates are a lot lower. In this study here, it was not risk adjusted, it was univariate analysis only, and they did find that the staple line reinforcement is associated with decreased bleeding rates. So again, decreased bleeding rates, we heard that in the prior study. It went away after surgeon level analysis. This isn't able to do the surgeon level analysis, but shows that bleeding rates are lower with staple line reinforcement. And it did not affect the leak rates in this study here, which is different than what was shown before. Again, no surgeon level analysis. But again, that leak rate went from 1% to 0.24%, which is dramatically different. Another paper here that was published in JACS using the same data set, only using the participant use file from 2016. This one did include a risk-adjusted model. It did show an improvement with regards to bleeding, as shown by the odds ratio here of 0.7. And so they said that there was a lower postoperative bleeding rate. In this study, risk adjustment was used. However, the outcome was organ space infection and not leak rate. So they didn't actually look at leak rates per se as we otherwise would categorize them. So that's a little bit different. And again, no surgeon level analysis in this study, but consistent with the prior one where the bleeding rates are lower. So what do we do with all this information? How do we decide? And what do we do? Now, one thing I didn't tell you was between that first study and the second study, the rate of no staple line reinforcement went from 20 to 23% across the country. So a little increase in no staple line use in that interval. So what is the summary here? Well, first of all, laparoscopic sleeve gastrectomy is very safe. The leak rate of 0.24%, that's 2.4 in 1,000, or the bleeding rate of 2.6%, 2.6 in 1,000 cases. Staple line reinforcement is associated with decreased bleeding rates by 1.2 events per 1,000. So the difference in those recent studies is 1.2 events per 1,000 cases. No wonder why a single surgeon can't figure out if it's better or not in their hands. You need this kind of large data set in order to do that. However, it's not clear that would still be significant when considering intention to treat or surgeon level analysis, because in that prior one with surgeon level analysis, that difference went away. Now there's likely little impact of staple line reinforcement on leak rates, so that's a good news from that standpoint. But really, there are so many variables that are not accounted for in this modeling with regards to surgical technique and patient factors. We talked about the surgical technique. We'll talk about more of those later on. We're talking about hypertension, hypercoagulable states, use of Toradol, use of antithrombotic agents in the perioperative setting. None of that's included in here, and that probably does have an impact on bleeding. So the impact of staple line reinforcement alone is questionable, especially because it's only 1.2 events per 1,000 cases. The costs of using staple line reinforcements are significant. Now, it's hard to get an exact number of what that is. We're going through the literature from different areas, but one might surmise that you would save about spend about $1 million to stop 1.2 bleeding events. So in summary, staple line reinforcement is certainly not required. As for me, I do not use it, but I'm very conscientious to control all my bleeding, and my 3 partners use staple line reinforcement, and I haven't convinced them. So thank you very much.